Right, this is Gary Allen, Advantage Dental, and thanks for sharing that story, or thanks to Teresa. This crosses a lot of DCOs. I think just about all of them were mentioned at one point or another. It's obviously difficult to respond, without knowing more about it. But it sounds like she's with us now, so certainly I can look into it and find out why she is not able to see a periodontist, because even though periodontists will not contract with us in Central Oregon, very few statewide, they will still accept our referrals. So that's not a deterrent at all. So, but I'll just need to get more information, background information on the member.
Okay, and Donna, Michaela, Teresa's full information is going to be shared with board members afterwards, right? At some point?
Yes, it will go out under a separate cover.
Okay. Thanks, Gary.
Michaela, I'm not sure if Teresa had included her contact information, so we'll want to make sure that we clear that so we can meet offline. Rick, I think you're on mute.
Doesn't matter. None of you listen to me anyways. And then I just want to acknowledge, it feels like old time's sakes. We have Mike Shirtcliffe and Lindsay Hopper at the meeting. And so welcome. It's good to see you. And we'll go on to the next item. Linda, Governance Committee.
Thank you. I'm just going to spend about 5 minutes or less on this topic. The topic is board alignment with the Regional Health Improvement Plan Future State Measures Survey. It's a survey that went out, I think about a month ago, right, Donna? And just to get benchmark where this is, if you guys will remember the last time we met in person, the day before the world shut down with COVID, we had our glorious strategic planning retreat. This is an item from that strategic plan. And it's about alignment of our strategic plan and all of our member agencies with the Regional Health Improvement Plan. So our efforts are directed in the same direction. As we were developing the plan, the members of the board felt that their own organizational plans should also be in alignment with it. So the survey was recently sent out to measure how we're doing on this metric. And I want to report back to you, we discussed this at the Governance Committee, that only 7 out of 13 organizations had completed the survey, and that there was no participation that shared the county public health perspectives and their activities that would be in alignment. So the committee felt there was a big missing gap, that the survey may have gone to county commissioners and the county commissioners maybe answered to the best of their ability, but didn't forward it to public health to get down in the trenches and see what activities and plans were consistent with the Regional Health Improvement Plan. So after a good deep discussion by the Governance Committee, the committee identified that the survey questions focused more on the organizational strategic plan alignment, as opposed to activities and other plans in the organization that are in alignment with the Regional Health Improvement Plan. So it's possible that someone responding, if it wasn't in their strategic plan yet, but it was in their, what was the term Justin used? Focused metrics and operating plans. So the committee recommended that we come back and share that we'd like to have you take one more look at it if you haven't completed it, because we really feel it's important to have 100% participation, and then to ask the county commissioners if they could include or consult with or refer the survey to the public health department, who knows what's active in their plans. And then we can review that next month at our meeting and bring it back, hopefully. Any questions or anything I overlooked from the Donna or the Governance Committee?
No, I would just add that I did follow up that meeting, sent the survey out again, and actually asked the county commissioners to do exactly that. So if there's any question or pieces of clarity that are needed, please refer back to us and we'll be happy to help you.
Thanks.
So I want to just toss this out. There's no way that this board can get into an individual complaint, but broadly speaking, around, I'm going back to the patient story. Is I remember when the CCO was forming, or CCO's movement was forming, and Mike Shercliffe, Dr. Shercliffe was in the middle of it and advocating for dental integration, and often frustrated with the structure and the setup of and the lack of integration and attention that dental has gotten. I'm wondering whether, and this is a wonder, is are there do there continue to be structural problems with how dentistry is included in the CCO setup? And would it be useful to generalize out of this particular complaint and try to highlight some of those issues? And so I sort of toss that off to Gary and Mike and see your thoughts.
Rick, my comment would be, I think as far as, if you're talking about integration of dental into with behavioral health and physical health, I think it really varies by CCO as far as how much attention they pay to it, but I would say that, quite frankly, Pacific Source in all of their regions has been pretty a model as far as integration, and really, I think how it was intended to be, although I'll let Mike comment on that, but it got off to a slow start. I think a lot of things that were pointed out in that patient story about recruiting dentists to participate in OHP and Mike was with Advantage when this happened, when we had the Affordable Care Act expansion and we ballooned up much faster than we could add capacity. And then we've seen something similar with the COVID expansion, where it's ballooned up without being able to add capacity fast enough. But we continue to struggle with getting, particularly specialists, and particularly specialists in Central Oregon to contract with us. So,
oh my gosh.
I mean, that's kind of a rambling answer. It's an ongoing issue. I think integration of dental, we've always kind of been the stepchild, not just in Oregon, but nationally. But I think efforts have been made and progress has been made to the desired outcome, but there certainly is still work to be done.
Rick, you want me to comment on it? Gosh, I came on to the first meeting in 3 years and you're right in the middle of dental, so.
Yeah. Well, we haven't talked about dentistry in 3 years, and so it's good that you showed up.
Well, my belief is you'll never drill your way out of this infectious disease until the rest of the healthcare system gets to the point that a drill, if dentistry's only tools of drill, they're always going to be looking for a hole. And until we get it ingrained to all of us that the hole in the tooth is a result of an infectious disease, and we address that, we're going to always be chasing holes that are developed. I don't care how inexpensive the driller is, you're still never going to catch up. And this story really reflects a lot of things. One is, why is the lady continuing getting to infectious disease and no one sat down with her and helped her get to the point where she can control her own disease? Two, she has health issues, and the reason she's been on every DCO in the place is because she's got a particular health history where that very frankly, without some case management, she's not going to be able to address because the typical dental office is not going to address. And so it's a behavioral health issue that needs to be integrated with the oral health in the fact that she's got a phobia that came from some abuse that the traditional dental is not going to be able to deal with. And that's where the integration could come in the CCO. And I was in the PEP meeting the other day and they were talking about case management. Well, this lady needs case management from a dental perspective because she needs to be managed because she's been in all 4 DCOs and she's essentially unhappy with them all, rightfully so. And so until you address the fact this is an infectious disease and get the disease under control, and 2, we help integrate the behavioral pieces of this, this lady's not going to be successful in the system. And that's where I always hammered away about integration is how do we do that? How do we get all 3 of us, physical health, behavioral health and oral health and transportation and everybody together so we can help a lady like this. And it's very frankly, it's a complicated problem. And she's a failure to the system because of that.
Okay.
Thanks for asking, Rick. Like I haven't been gone.
Yeah, it's great. Have you right here, and pretty soon we'll have Lindsay giving us a report too, and I'll feel really grounded then. Brad,
Thanks for the opportunity, Rick, to comment on it.
If I could just ask one other follow-up question. So based on what Ralph just shared, which I really appreciate.
Mike is his actual name, but go ahead.
Oh, okay. Mike, sorry, it says Ralph. Could somebody comment on the behavioral health piece? How does that come into this, into our health system, and how can Teresa access that as part of her?
I don't think that there's been any efforts that I'm aware of to actively integrate dentistry and behavioral health in the way that Mike is talking about. There might be some case management offered out of the health plan, and I don't know about that. Our efforts to integration has usually been trying to talk dentistry into taking a look at our patients, especially our substance use disorder folks. But integrating the other way to deal with trauma folks who are trying to deal with dentistry, we've not done that, and that's a gap for sure.
Can I interrupt one thing? Is somebody in the system overview, which would be the people with the CCO, the light should, in my opinion, the light should have gone on and said, wait a minute, this lady's failed in the system because of these reasons. Rather than thinking, well, dentistry's not doing her job, behavioral health's not doing their job. It's this lady is failing the system for some reason. And that I think is a piece of the integration that I don't know how that gets put together. But that's, when she's failed all 4 DCOs, and she talks about this kind of issue, somebody else in the system knows she has the issue. And that's a piece too, that's a tough one.
Yeah, and so where I wanted to make sure that we stay on is, does this highlight a system issue? This board isn't qualified to talk about, the specifics of her case or whatnot, but does this speak to gaps in the system that we maybe in the future may want to advocate for? And that's just sort of what the angle I'm trying to keep us on with this one.
Maybe just a final comment, what Mike referenced as far as care coordination, and we had that presentation in the PEP meeting. That is available to members. And actually, I think, again, it varies by CCO, but care coordination, when you get all the organizations together, all the elements, it works pretty effectively to help navigate people to care and get their issues taken care of. So I don't know if this particular member has entered into care coordination, but I think that would be something that would be worth exploring.
Okay, so I don't want to do any more of a deep dive in this. I just wanted to keep this at a systems level. Brad, you get the last word, and I'm going to move on.
Okay, yeah, just so what is who is the player in the system that provides care coordination, case management for this type of case?
We
I think-
normally
I think-
get them. I'm sorry.
Oh, go ahead, Gary.
No, I was just gonna say, they usually come to us, for example, from a variety of sources, but typically from the CCO, that they enter into care coordination through the CCO, and then refer to us for the dental piece, but the other pieces are being managed by the CCO in our experience, although we do get them from other elements as well.
Megan and then Dan.
I wonder if this story is sort of highlighting an opportunity with the DCO construct having 3 DCOs under one CCO, all of which have case management, and she's touched all of those organizations. Is there some, not to solve today, but some sort of system opportunity, because there's a lot of potential case managers, but not all of them have the whole vantage point of what's going on with this particular patient. So I think that's another system thing to observe, but again, not solve today.
Right. And Dan, did you want to jump in? You had something in the comments.
Yeah, I was suggesting that a likely follow-up angle, if this person isn't connected there already, would be the CCO's complex care coordination program, where we have member support specialists and nurses and medical directors who are, it's very typical that they would wrap their arms around patients or members like this and make sure they're navigating through the system. So I just wanted to remind people who don't know that exists as well. And as Megan said, those programs cross every system within the CCO, everybody under contract and many community agencies. So there's sensitivity relative to an individual case, but those programs exist and are robust.
Yep, for sure. Hear about them often. So good. Again, I just wanted to see if this was one of those cases that could highlight some systems issues. Again, we're not qualified to dive into the particular case. So good. Thank you very much for looking at this. Gwen Jones, you're on.
Hey,
Oh, yeah,
Rick,
Dan.
sorry, can I go back to Linda's really good update for a minute?
Sure.
One of the things that I noticed about that survey is, one, it was very thorough and very detailed, but there were a lot of questions that probably could have been answered with some variability based on who was responding and how. So a lot of questions went into some of the really detailed areas within the regional health improvement plan and sort of said, hey, does this program or this metric or this thing align with your strategic plan? And I know a lot of organizations have strategic plans that don't get into little micro initiatives. And so for me, there was a potential disconnect between saying, is this something that's really in our strategic plan versus do we have operational areas touching this, focusing on this, resources dedicated to it? And when the latter was the case, I just tended to answer that, yes, we have good alignment, even though it may not be found explicitly in our strategic plan. So I didn't know if others had that challenge. It was pretty detailed in that respect, and it made it hard to just sort of connect the strategic versus the operational. And it might introduce some variability there that we may just have to wade through as we look at those results. So
Yeah, I had a very similar experience, because what's on the strategic plan right now is, whatever is the moment. And oh yeah, we did that strategic plan 5 years ago, and it's in alignment. And it's not in the strategic plan now because it just works. And so I don't know if I fudged on those questions or not. I don't know how I answered them anymore. So
and I think that's my point, is therein maybe lies a challenge. If we get a certain result, is it reflective of was Rick fudging to the left and I was fudging to the right, just based on the way that that some of it. So I just wanted to point that out for a cautionary note when we try to interpret the level of alignment quantitatively.
Okay.
Thanks, Dan.
Are we ready to go over to Gwen now? Okay, you're on.
All right. Hi, everyone. So we're going to shift. We're still going to be talking about strategic plans, but a little bit different. So the board, your board strategic plan identified equity as the goal. You've heard this various times over the last year. And the board has had historical conversations about your desire for an organizational commitment to diversity, equity, inclusion, and justice, but you want it with action and accountability. So CODI, the Central Oregon Diversity, Equity, Inclusion Committee, the DEI committee of the Health Council, and staff have answered that request and come to you today with a diversity, equity, inclusion, and justice statement and action plans. CODI is specifically seeking formal adoption of the statement as a public commitment made by the Health Council to building an inclusive environment that's welcoming to people of all people of all backgrounds. And this statement would serve to guide Health Council culture, thinking, and practices. So many of you have seen the statement. I'm also going to put it on the screen. It's included in your meeting packet as well. And you can see as the first page and a little bit onto the second is the statement itself. And then the second page provides some background around why this is important and some numerous links to add highlighted education and interest and context to the importance of this statement. So I'm just going to let you take a minute or two to scan it over. Many of you have seen it before, if not once, maybe twice. Some of you, this may be the first time seeing it. So this statement took CODI over a year to create. And you can see on here a list of organizations, staff and employees that participate in CODI. It's a pretty broad breadth of folks from a variety of organizations and a variety of roles. Additionally, as this draft was finalized, the commitment statement was vetted with community partners through all the work groups and all the committees. Many of you experienced that as well. And then the folks were asked to give feedback and express concerns or a level of approval. We had 38 folks respond, and it covered all the work groups and committees that the Health Council houses. And 100% of folks indicated that they highly approved or approved the statement. And you can see a couple of those comments that were shared. In conjunction with the commitment statement, there's been substantial behind the scenes work creating and actualizing concrete actions. If you remember a couple of years ago, it seems like a lifetime, you all completed the Meyer Memorial Trust Diversity, Equity, Inclusion Spectrum tool. It's a tool that assesses 12 different dimensions and gives direction to where an organization is on its DEI journey, and it helps to identify potential areas for future work. From those dimensions, CODI identified priority focus areas for the next 3 years and developed action plan around that. The priorities that they identified are training, policy, and data. This provides some background to the story behind CODI specifically. This is a quick refresher on the Meyer Memorial Trust spectrum tool. But really what we want you to see is the action plans around those 3 priority areas, policies. You can see the logic model with specific activities. This is down and dirty, much more detail than you probably want, but indicates the work that's currently happening and will happen, and the outputs that are expected, and the impact, why we're doing those, why these actions are and what they'll be achieving. And then training work around training, developing and implementing learning and growth for staff, management, and board of directors. And finally, data. Routinely collecting and analyzing disaggregated data for programmatic and operational work, and using it for planning and decision making. And then finally, we created a simple-ish crosswalk between the CODI equity work and the board of directors equity activities that you have on your strategic plan. All aligned around the 3 priority areas around training, data, and policy. So any questions of clarity about the action plan or the DEI statement at this point? Because what we're coming to you with, what CODI's coming with you, is that wanting you to see that the commitment statement and the action plans are well underway. And CODI, again, is asking you to adopt the diversity, equity, and inclusion and justice statement commitment as a public commitment by the Health Council to building an inclusive organization. And what I understand is that the board's usual practice is that you receive and review a recommendation 1 month and then review it the next. Or given your familiarity with this request, if you're ready, you can review it and vote today. I'm going to hand that back to you all to decide how to proceed, and any conversation I'll ask Rick to follow. Happy to answer questions in the interim.
Okay, thank you. So we have a request from them to approve of this. So the question, are there any questions or comments on Gwen's presentation?
I mean, Gwen, first of all, like, hats off to you guys. This is a lot of work, and I know it's been going on for a while. There's been really good dialogue and passion behind it, and it shows, and it's very well thought through. I think the hard part is going to be, how do we actually affect change? And but I think this is a really excellent framework, and I think if uniformly as a community everybody can come together and just kind of adopt this framework, then how do we then, I mean, I think we can make a difference. I just think it's going to take a lot of work, and hopefully some metrics to measure against how we're making this progress, and it goes beyond healthcare. So it's going to be how many other communities and who's willing to really step up and be part of this.
Linda?
Divya, I'd like to just follow up with your comment, maybe to just let the rest of the group know that staff on the work groups, I know at least on the work group that I'm in, which is the upstream prevention work group, already has, where your organization is from a grantee perspective, and you get points. If you haven't talked about DEI, then you won't get any points for that. If you're in discussion about DEI or developing a policy, you get some points for that. If you've already got one in your organization and you're doing training, you get points for that. So it's a small way, but it's a way we can gather data on over year to year. Our organization's actually developing plans and integrating And where is our funding allocated among those organizations based on the work they're doing around DEI? And so I've been really delighted that staff is doing, and I've been feeling as a board member a little deficient because we don't have a policy ourselves. So I think it's really critical that we, if we have to wordsmith it, great, we can do it next month. But if nobody has any major issues with it, I'd like to propose we pass it today.
Gary?
Yeah, just a question, Gwen. You showed some additional documents beyond just the statement. I don't know if maybe you sent those out and I missed them. But you know, not that it would hold things up today, but it just looked like a good implementation plan. So I'd be interested in seeing those as well.
Yeah, happy to share. For the point of the discussion today, we didn't want that to sideline the adoption of the statement, and because the action plans are so detailed, they're detailed, and even what we're showing you here is higher level. So, but we can definitely touch base with Donna and send that out as well.
Well, and I think that would be sort of one of my concerns, and you're addressing that concern in advance, so that it's really easy for organizations like this to pass high-minded, fine-sounding statements and do nothing about it. So that you have an implementation plan that you're deeply doing something about is reassuring.
Yeah, and what I can interject too that I failed to mention is the statement as well as the action plans are going to be living on the website. So we recognize that they are living working documents. This is going to continue to evolve as our work changes, as knowledge and learning change, as the environment changes. But it's also going to be publicized, so anybody will have access to it. Our hope is to make it live on the website in January, along with a number of tools that Cody has been working on in partnership with some other community organizations as well. So there's a lot coming in addition to the work that's already happening this last year.
Okay, Brad?
Thanks. Yeah, I just want to acknowledge all the work you've done. It's fantastic. And the fact that so many different eyes and minds have, vetted what you've come up with, the final product, which again, it can be changed over time, but it's, I'm impressed. And I think I'd like to support Linda's proposal that we accepted, as long as there's no, strong disagreement or.
So I'm hearing a motion from Linda, and I'm hearing a second from Brad. So I hope staff caught that motion. Do you want to restate that motion, Linda? You're on mute, Linda.
I move that we adopt the policy as presented today.
And I hear a second from Brad. So discussion, just wanted to make sure we're on consensus or whether there's need to discuss this further. Silence is assent. So all in favor, say aye.
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 Opposed? Abstentions? Okay, passed unanimously. Thank you.
Thank you. And I want to make sure due credit is given to the Cody partners as well as Ignatius and Renee. Without the collective work of all the folks and many of the names you don't have in front of you, this wouldn't come to be. So thank you very much for your support.
Good job, Gwen. Okay, Tricia, you're on.
Hello,
Third quarter
everyone.
report.
Yes, the page with the yellow, green, and red in the little teeny tiny font. I want to let you all know that we're working towards improving this document, and we hope to have that in front of you at the beginning of Q1 next year. But until then, I'm not going to go through this one at a time, but I do want to just cover a few highlights and then open the floor for questions. So if we could just first scroll down to the budget. Let me see where that falls. goals under financial stability. So I want to start with some small opportunities. And as you look at this as a whole, there is a lot of green. So there's a lot to be celebrated in this space. And to be clear, we are meeting or beating the budget right now. But why I wanted to call this out specifically is that the JMA shared savings, there's an estimated recapture of 1.7 million. And I think just to spend a moment, and I want to be clear in my fourth month of this role that I am not an expert in this space. I'm going to let you may hear my voice sharing the updates, and then perhaps Leslie or Dan or someone else jumping in with some more details. But this is my understanding from finance, is that the recapture is coming out of 3 different places. And again, although we're exceeding our budget, it's a few things. It's prior year's items that are flowing into the current year that make it this year look a little bit better than it actually is. So be aware of that. The second place to really dig into this is within the liabilities on the balance sheet for withholds and projected provider incentive payments. And again, this is really digging into the details of the work that the finance committee does. And then I think the last thing that points to, as I understand from finance, to a current recapture is that there's both higher claims for emergency room visits, and then there's also higher inpatient admit rates that were higher than we budgeted. So that's probably not a surprise to anybody. And if you get a chance to review the finance committee minutes, there's 2 really nice charts that finance puts together that highlight that at the end. So I hope that's a little more helpful in that space. I think the good news, if you look at the director's report that we're not really going to go over in this moment, but is that there's a very clear pathway in the next 6 weeks for the budget to be approved. And these items will be discussed in detail during that committee. So how about if we move on to a few of the things I just want to highlight, and we'll come back to the last yellow box, because although it's yellow, it is positive. So I'm just happy to announce that we hired a workforce development program manager. This is under required plans. If who is driving wants to slide down, great. Yeah, I know it's a lot, this page. So, but we've hired Cheryl Cohen. So if you're a stakeholder in that space, keep an eye out for an email, a connection point. She'll be reaching out to you. So we're excited about that in our current staffing world we all live in. I also want to just highlight, at the end of October, OHA approved the CCO Share Initiative spending funds. And this was the money that went to Fuse. They were very pleased with a number of alignments in that space. And I just want to give a shout out to the CAC and also to Kristen Tobias for their great work in that space. And the last item I just want to highlight in the sea of green boxes is that the transformation quality strategy was posted from OHA, and out of all the CCOs, we were amongst the highest in the scores. And the transformational quality strategy, this is under TQS, I know, right? It has its own header. Okay, well, we definitely have some opportunity to improve in this presentational space. So thank you for sticking with us. But it's exciting when we submit things, and we really enjoy seeing our scores being at the top. And this is the TQS is complex, crosses many different work streams, from improving access, behavioral integration, health equity, grievance and appeals, social determinants of health, just to name a few. So when these scores come back positive on our proposed work and work that we're doing at the beginning of 2.0, that's exciting for us. Now, the last thing I want to talk about is the very top box under quality. So give you a sec, there you go. Give you a second to scroll up there. So this has been the focus of a lot of discussions this year. And I believe at this point, probably most of you know that OHA's Metrics and Scoring Committee rebased the quality for 2021. So what that did was lower scores, which made it considerably easier for all of us to achieve our goals in quality this year. You know, due to the pandemic, we weren't all able to do all of the quality work we'd hoped to achieve, you know, because we were operating in a need to and a have to space in so many places. So the good news is we anticipate this going to full green to 100% payout. There are 2 metrics that our population health team is focusing on, and you'll see those under oral evaluations for patients with diabetes. And the other is well check. And if you just scroll to the right, you'll see where I'm speaking on the very top box. Scrolling all the way up. To the right, to the right, to the right, quarter 3 to the right. There it is. Well checks. For 3 to 6 year olds, we only have 82 for the gap to goal and 43 members for gap to goal. Our population health team actually thinks this month we could be achieving those goals, which would point us to 100% payout. Now, I also want to point out the emergency outcome tracking for COVID measure carved out 5% for meeting that metric. So even if we meet all the other metrics, our maximum payout could be 95%. We are not currently meeting the COVID-19 vaccine measure. We believe that we could meet it as an overall metric, but also believe we are unlikely to meet it in all the races and ethnicities. So that has been a challenge here in Central Oregon. And to be really transparent, we are lagging behind all of our CCO, Pacific Source CCOs in that space. So that's been hard, but again, 95% payout. When we were reporting only a few months ago, we anticipated this being 70% is a huge win for our community. That's all I have for today. I'd love to take any questions anyone has on the report and ask Leslie to answer them. No.
Hey, Tricia, this is Brad. Would you just repeat the last statement you made about access and that you're disappointed, and just expound on that if you could?
Sure. All our other CCOs, Pacific Source CCOs, so there are 4 of us, they are all exceeding this metric in all categories. So, you know, this has been a place where we have been lagging behind and challenged in meeting the minimum numbers for people to be vaccinated in our communities.
You were talking specifically about vaccination rates.
Correct.
Okay.
Yeah, it is the COVID outcome tracking metric that is likely to create a 95% payout instead of 100%, where we would normally be pointed. But when this emergency metric was created, they carved out 5% of the total if you have success in the space, which we are currently not on target. Although, again, 95% is so much further than we were ahead of just a few months ago, thanks to the rebase.
Tricia, do you know what the how the Central Oregon CCO vaccination rate compares to what's going on in Eastern Oregon? Are we low compared to Eastern Oregon? High compared to Eastern Oregon? You know, because the theory would be, well, you're comparing us with the Valley, and there's clear cultural differences. And so the other comparison would be to test that theory is, well, Eastern Oregon's, you know, when I've gone out to Eastern Oregon, there are no masks and there are no vaccines apparently. So, but just wondering what that looks like from the data perspective.
You know, Rick, I don't have that data at my fingertips, but I think that's a really worthwhile path to go down. And I'll see what I can find and report back on that.
Okay.
Tricia, if those scores don't rebase, or are they going to stay rebased for next year too?
Yeah, so this is a glide path, which increases a little next year, and then the year after gets us back on track so where we were really pre-pandemic. So we do get, and I don't have that up in front of me right now, but we will experience some benefit in the quality arena in reductions next year as well.
And if it hadn't been rebased, we would have missed quite a bit.
Correct. And we weren't alone in that space, which is why the metrics and scoring committee did this work, understanding that the pandemic was just beyond anyone's ability to really focus on all this quality work. And I know specifically you, Justin, and your team, and many teams are working with population health to already help ensure that systems are in place starting right out of the gate in Q1, so that we are not in a catch-up place, but we are really moving forward towards those metrics right as soon as we can. And again, we think this month we will be able to report that as green. So it's really impressive, the work that's being done with so much that we can't control. So keep
Tricia, I just wanted to make a shout out to the Operations Council for partnering with the Health Council and putting forth really the first letter that we've ever pulled together on letterhead to talk to metrics and scoring, and hats off to Amon. And I know Charity's not on the call today, but really carrying the water for Central Oregon. And that, I mean, that letter literally could be worth $15 million to the region. So I just want to say thank you to all of you and most all of you have staff that signed off on that letter, and your organizations were supporting it. So thank you.
Yeah, absolutely true for all the community members, and especially true for anyone who sat in on that 6-hour meeting. Thank you.
I would comment that I think that much of the healthcare system is experiencing serious staffing shortages, which really are impeding attempts to work on quality metrics. Earlier in the week, last week I pulled up. We have our strategic plan, and then we have operational plans for each department. What are they working on that addresses the work plan? And so I'm looking at the work plan, and it just laughed at me. Oh no, we have to deal with staffing shortages and address that before I can deal with the rest of implementing my strategic plan. So and I don't think I'm alone in the healthcare system. So I think that's sort of our challenge going forward operationally. Okay, thank you very much for that report. Any other questions for Tricia? Great job.
Thank you.
And for Executive Director recruitment update, Justin, you're on.
Sure. We had our first meeting. It was a great kickoff, I think. We were able to walk through and have a conversation about which staffing agency we wanted to use and how to make sure that the DEI criteria was in sourcing candidates. I think we had multiple different viable options that we could have went with, but having News Express before, I believe the general consensus amongst the group was to go on ahead and talk to Express and see if they could write the DEI criteria into sourcing candidates for us. I know Donna did that, and we're good to go. I think we are meeting with them this week or next week. I'm sorry, next week. Sorry, my mistake. We're meeting with our recruiter next week to begin the conversation of kind of what we're looking for. I do think that was one of the questions ultimately that the group had when we came back. Obviously, we're looking for strong leadership criteria and all of that, but we also did want to know if there was if the board wanted to weigh in with a specific list of skill sets, or I know the job description really lays that out, but is there a higher level focus on what you want when we're screening candidates? So overall, that was our first meeting, and we're happy we made a decision and got moving. So you guys let us know if you have criteria or a different approach you'd like us to take.
Any comments about that? I just want to appreciate Justin and the other members of the recruitment committee helping out. I am happy to join in once we get to interviews. It's just could not participate in it right now with that work. So appreciate it. And, you know, I think one of the things to sort of square, Commissioner Dare pointed out, and this can be confusing, in Deschutes County, there is a very high vaccination rate going on. But conversely, the Medicaid population remains quite low. And so I think that points to some socioeconomic divides that happen, especially in Deschutes County. So overall, the county's doing well, but within the specific Medicaid population that the state is measuring the CCO on, it's not, we're not so strong. So, and again, I don't think that's really about the CCO or the healthcare system here. I think, you know, these larger socioeconomic political forces drive these things far more than our systems can really change. So I think that's sort of a comment to square Commissioner Dare's comment. Yeah. Okay. Rick Blackwell, you are on the 1115 waiver.
Thank you, Mr. Chair. Council members, I'm Rick Blackwell. I'm the Director of Government Relations for Pacific Source for Oregon. Thanks for giving me just a few minutes to give you an update on the 1115 waivers, which is not something you sign at the climbing gym. It's actually a much different process than that. I want to just, you know, my lawyer brain always starts with a baseline, right? What are these demonstration waivers that the federal government allows states to pursue? So basically within the I think it's the Social Security Act, the Health and Human Services directors can allow states to request that they waive portions of programs otherwise required by federal Medicaid law. And the idea is that where these initiatives are experimental, pilots, or demonstrations, and they promote the objectives of the Medicaid program by, for instance, providing affordable health coverage. In all cases, though, a waiver that the federal government grants to states are budget neutral for the federal government, meaning that the budget requests, you know, the Medicaid program, CMS would not expect to pay more if they approve the waiver than if they did not. The Affordable Care Act does give put some transparency provisions in place for this program, so that there are notice and comment periods that are now required whenever a state requests a waiver from CMS. And so there will be, I'll get into this in a minute, but there is a 30-day comment period that starts when there's a formal application up until transmittal. And so, of course, waivers do change from administration to administration. The current one that Oregon is operating under is really an extension of a 2017 request. And so this is kind of, I think, the time the state's looking to make some big changes for the waiver. Past waivers have really significantly shaped the Medicaid program in Oregon. So for instance, the prioritized list of services is a product of a 1994 waiver. Children's health insurance is 97. Obviously, the coordinated care model and the transformation that's gone with that was actually as a result of a waiver from 2012. So we really pay attention to these waiver requests because of just the large impact on the system and a very large impact on the state budget. OHA is one of the largest funded total funds agency budgets in the state, something around $20 billion. So for 2022 to 2027, the waiver process is starting. About January of this year, the governor kind of reopened the process with a letter to OHA saying, here's kind of the 4 general areas I'd like to you'd like you to focus on, including what you learned in CCO 2.0. OHA has engaged a lot of interested parties in developing a series of concept papers that kind of set out the broad policy goals that it wants to achieve through the waiver request. CCOs have worked with the health authority, including Pacific Source. So have a lot of groups like regional health equity coalitions and the like. So they're getting a lot of feedback from all members of all, I guess, a lot of communities within Oregon. The concept papers have been around since June of 21. So we made some comments on the first draft. They had been delayed. There was a lot of work that had to be done in the redrafting, but the final papers, I guess, quote unquote final, were released in November 2nd. So just not too long ago. That 30-day trigger that's in the Affordable Care Act will start around December 7th. That's when the application will be released for public comment. And then the comment period ends on January 7th. And within there will be some listening sessions that OHA is going to hold, as well as briefing both the Medicaid Advisory Committee, which is a subset of the Oregon Health Policy Board, and then also the Health Policy Board itself. As far as the content that we're looking at right now, and again, we're still going through them at Pacific Source, and so I won't necessarily have a detailed set of here's how we're approaching these, but I did want to make sure you understood kind of what was in a general sense what's within the papers. First one has to do with maximizing coverage through the Oregon Health Plan. This really has to do with eligibility changes. So 2-year eligibility for children. Children 0 to 6 would have eligibility in the Oregon Health Plan. And then there's a alignment between the SNAP application and the Oregon Health Plan application, which makes a lot of sense. When I read that, I didn't think that was even an issue, but apparently it might be for data use purposes. So that's one thing that, those are kind of the things that are within that paper. There's another paper around improving health outcomes by streamlining life and coverage transitions. This is really trying to address what happens when someone interfaces with an institutional system like the Oregon Youth Authority, the Oregon State Hospital, or the correction system. What kind of transitional care can one expect to see as they move out of those institutional settings? There's also more seamless coverage for youth with special health needs. I think I don't know if that's a term of art under law or not, but proposing a coverage until the age of 26 for that cohort. And also then asking for expenditure authority from the federal government to help with the community-based organizations that might provide for social determinants of health defined benefits in that paper. There's paper on the value-based global budget. It's really high level in my mind, and I'm not even going to pretend I'm an expert in global budgets. All I can tell you is that it does look like there would be a more predictable path for budgeting with more of a 5-year budget setting process rather than what happens now, which is really a biennial process that's really tied to the state budget. And then, the capitated budget would be developed through looking at multiple years of data. I think what data they look at is going to be particularly of interest to me, especially since we've had some really interesting, care patterns over the last couple of years due to the pandemic. And then there are some provisions in that global budget paper around how do you address the cost of prescription drugs? Do you look at drugs that have had an accelerated pathway through the FDA? Is there ways that the Medicaid program can respond to those? Again, these are ideas that OHA is asking for the state to waive. I mean, I don't know how successful some of the ideas will be received at CMS. It's all part of a negotiation process. One I did want to flag for this group is a paper on what's called focused equity investments. So I think everyone's probably fairly familiar with the cost of growth target work that's been happening in Oregon. So this is setting basically the medical cost of inflation at 3.4%. That's the benchmark that Oregon would like to see the entire system kind of attain in terms of reducing or limiting the cost of growth in Oregon. What OHA would like to do is take the difference between what CMS expects to spend on Medicaid, which is around, I think, 4.9%, if I remember right from one of the papers. The difference between that and the 3.4% rate of growth, and use those savings to help communities drive decision-making in terms of investments that might bear on health equity, right? So that could be any number of things that are health related. To accomplish this, the paper is proposing what the paper is calling a community investment collaborative, which, if you look at the paper, looks an awful lot like the model here, in that CCOs are expected to be part of it, but not lead. That the community is the one driving decision making. I think there's probably still some more detail that we would need to see in that one. The first paper talked about a zone that was set up that may or may not run parallel to any processes that were happening in the community. So I'd flag that one for this group, just for maybe some further look. And then the last paper really is about bifurcating the metrics that we, I think partially what we talked about earlier, into upstream and downstream metrics, right? Upstream being, what are metrics that can help prevent or address social determinants before you get to the downstream, which is actual healthcare. So these are pretty consequential papers. I think they've been included in your board packet. My only ask is really just to take a look. I think OHA is really looking to hear from everyone. We're just one part of a broader community. And so, I just want to make sure that I got the word out there that these are still around. So I don't know, Rick, if there's any questions that I can field. I wasn't planning on going a full 30 minutes, which is maybe merciful at the end of the meeting.
So do we have any questions or comments or thoughts? I would say that we would want to track pretty carefully how OHP plans to do the rate setting process, because any utilization that's happening now is just marked by distortions caused by the pandemic, and both good and bad, right? And so some utilization's going artificially up, some utilization's artificially down. What you make of it, I don't know. And I can dive into my own organizations and point out all the distortions, and I'm pretty sure that those similar levels of distortions are happening in the hospital systems and in the primary care system and specialist system. So I would just be we want to be paying close attention to how they come up with that, given a data-free environment.
I think the challenge for the health authority is that block grants are not terribly favored within the administration, but the global budget can appear to look that way. And so I think they're trying to thread a careful needle, and I understand that would be a tough one to. So I think more to come on that one as to how that one's negotiated with CMS.
Okay. Any other comments? Dan?
Rick, you and I get to talk all the time, but I haven't asked you this question. Is there any indication from states that have gone for waiver approval in the current administration's CMS leadership that would tell us what they might push back on or not, and anything from the lay of the land in the other 49?
Yeah, that's a good question, Dan. And actually, hi, Lindsay. So, some states Oregon is going to be in line with a number of other states, right? Including some big states that have waiver requests. There's some things that we can point to that we think would maybe be automatically approved by CMS. For instance, Illinois in its waiver requested 12 months of postpartum care as part of their waiver, and that was approved. So I think we could reasonably expect to see that. But I think, there's a number of states, to your point, that are also waiting. The federal government took a while to staff up. CMS itself didn't have an administrator for a while. And that the leadership vacuum does really make a difference in how decisions are being made. So I wish I had a little more information on, maybe what's a major waiver looking like. But I think at this point, a lot of us are kind of waiting to see what happens with larger states.
Okay, anything else? Okay. I'm assuming that what's listed under the raw and rip is adjourn. So that's the agenda item for raw and rip. So we're at a point of adjourning and moving to the executive session to cover some personnel discussion.